So people come to the office for a number of reasons. Generally, we start seeing people at the age of 18 for wellness exams, and then that should be every year. When you come to a wellness exam, we will do a physical exam, talk about how your periods are, if your birth control needs are being met, if you have any concerns about that. And that starts again at the age of 18. The other reason people would come to the office is if they're having a problem. So for example, if you're having pelvic pain or heavy periods or long periods, painful periods, or having pelvic pain, you would want to come in and get checked out. And if you're sexually active and want to get tested for infections or discuss birth control, that's another common reason people come to the office. When you come to the doctor for a checkup, you check in at the front desk, and then usually they'll have you come to the back and leave a urine sample, and that's in case you have any urinary symptoms or need a pregnancy test done. So we like to get that before an exam. An exam is less uncomfortable if you have an empty bladder. So that's the other reason to go to the bathroom. And then you come into the room, you'll get your vital signs checked. We'll come in and talk to you, talk about whatever concerns you have, do the exam, and then you're able to go home. A physical exam and a wellness exam includes a breast exam, and an abdominal exam and a pelvic exam.
A lot of people are nervous their first exam, whether they know what's going to happen or don't. So I feel like the biggest fear is what's going to happen. Most of my exam, your first visit, is longer than any other visit because we have to spend all this time getting to know you. In my practice, I get to know you with your clothes on. So I come in the room while you're dressed and we meet each other, and I tell you my name and I tell you about my kids, and I tell you, that I do this because I wanted to take care of women for their whole lives, not just pregnancy, not just one thing. The last 5-10 minutes is a quick exam where I listen to your heart and lungs, and I teach you how to do a self-breast exam, and I feel on your abdomen to make sure your organs are growing appropriately and they're not oversized or undersized, and make sure you don't have any unusual pain when we press on your abdomen. For the part that most people are nervous about, it's the pelvic exam. Most pelvic exams are not painful. For most people, it just feels like pressure. The speculum goes into the vagina and puts pressure on the rectum and the anterior or top wall of the vagina. So it feels like fullness, but it shouldn't be needle-like or sharp-like or knife-like. If you're sexually active, we can consider doing a pelvic exam, but based on what's going on in your life. And if you're not sexually active, then I don't require, and a lot of providers don't recommend a pelvic exam unless you're having a problem. A pelvic exam consists of a couple of things. The first thing is we just look with our eyes. So we're here to look at your skin, we're looking at your lymph nodes, we're looking at your anatomy, and then we do an internal exam with a speculum, which is the device that kind of opens the vaginal canal enough for us to see inside the vagina to the end, which is where the cervix is. And then we do an internal exam with our hand called a bimanual exam, where we use two hands. We use 2 fingers inside the vagina, and then we use our hand on the outside of the belly to feel the size of the organs of the pelvis.
We do pelvic exams for a number of reasons, not just for wellness visits. We do them when people have pain and we're feeling to see if their ovary is enlarged or their uterus enlarged, is there a cyst or a fibroid or a mass or something. Do they have evidence of an infection, a vaginal infection, or an upper genital tract infection like in their fallopian tubes or uterus, and is that why they're having pain? So there's a number of reasons we do exams. So vaginal exams can be uncomfortable. It's a little bit awkward. One of the hardest parts is you have to kind of scoot to the bottom of the table and relax your legs, and that's a hard thing for people to do. But really, if you can relax and if you can position properly on the table, it's really not that bad. It's something that everybody's anxious about, but it's quick and you can do it.
We are very good at this, and we're very good at making sure that we don't cause bodily harm, and most pain comes from bodily harm, right? So if we're not injuring your tissue, it's more than likely not going to cause you pain. And if it does, tell your provider. Ask them to stop, because it should not be painful. And if it is, then we need to make an adjustment.
So some of the tools that we use to do an exam, the most common and sort of the thing that people are most anxious about is something called a speculum. And this is a speculum. And what happens is we put this little light in it, and then it lights up and shines a light inside so that we can see. This goes inside vaginally. We open it up, and we're able to see the cervix at the end through here, and the light helps us see. It comes in a couple of different sizes. So there's a smaller one for people with a smaller vagina and a larger one for people with a larger vagina.
Prepare yourself by asking yourself, what am I nervous about? and then asking questions about what you're nervous about. Because if you have the information, a lot of times it takes away the fear. Most people fear the unknown. If you're nervous about an in-person visit and you're nervous about a pelvic exam, then we can talk to you about what to expect beforehand. The other thing that I often do for any exam is explain what to expect. So just talk to your provider and ask the questions about the things that you're scared about, because they will likely have a way to help you through that fear.
I was 17 years old when I got my first pelvic exam. I was nervous about being uncomfortable and being exposed to someone that I didn't know very well. When I got there, they had me fill out a little kind of like get to know you thing where they just want to know your medical history and some information. And then once I was called in, we talked about some stuff. She did the pelvic exam just to see if there was any abnormalities. And I also took a couple blood tests just to make sure that I was healthy. It's just like a regular checkup where the doctor has you take some deep breaths and make sure like your joints are all okay. It was just like that. It was just in an area that typically isn't examined.
I was 17 when I had my first women's clinic exam. My exam was just a general checkup, and it was to analyze me for getting birth control prescription. I've been having problems for a while, and I was kind of a little apprehensive to getting an appointment. I wasn't sure if my mom would like it, but I was just relieved when I got in there and I was able to get a prescription, which that prescription is helping me. It's helped me the past couple of months, so it's been a good experience.
Trust the doctor, know that you're going to be okay. And I mean, there's a reason they got the degree that they got, and there's a reason that they're doing what they're doing. It's because they know what they're doing.
So basically what's changed since the last time we spoke is the emergence of this pandemic, this global pandemic known as coronavirus or COVID-19. And that's really changed medicine in our country dramatically, and the way that medicine is practiced, the way that healthcare is delivered in our country. We have started doing what's called telemedicine for our gynecology appointments, and we're going to be switching most of our obstetric appointments to telemedicine as well, which basically means that in a setting just like we're doing right now, I'm conducting office visits. I tell them I'm going to be looking at your face, not at the camera, and then they laugh and they're like, I'm doing the same thing. And so we're just trying to relax people before at the start of it so that they're not nervous. And I do that in the office too, but it's, on the video, it's a little, what's in the background,
There's lots of reasons that we're seeing people at our clinic for telemedicine-wise. Problems with menstrual cycles or periods, problems with mental health, complications of pregnancy, or complications from birth control are the main things that we're seeing.
In the office, we're wearing a regular mask, like a medical mask, and kind of discussing whether we want to wear eye protection like goggles or face shields right now in the office. We are not seeing anyone who's sick in the office.
So not only are we reducing visits, but the people who do need to come in, who are about to have their babies or who are having an emergent gynecologic condition, we are screening via phone before they come in. So they get a phone call that says, are you having any of the basic symptoms of coronavirus or a fever? And if they are, then we're having them tested prior to being seen. So we're getting all that set up. And if it's somebody that needs to be seen emergently, then we are sending them through the emergency medicine where we have privileges. But if it's not an emergency and they complete their testing and they still need to be seen before their results come back, then we're treating them as they have this virus. And we're seeing them with full protective gear.
It's very stressful. I mean, I haven't slept through the night in probably 6 weeks. I wake up thinking of things and worrying about things at 1 a.m, like, oh, you know what? I forgot to make sure that we do this. What should we do about that? Because we're constantly, I'm on a lot of committees. I'm on the physician leadership team. And so I'm privy to a lot of information and a lot of the planning process. And so it makes me think about this all the time. And so I try to take breaks from it when I can, but my mind is on it 24 hours a day. I'm thinking about how this is going to impact us. It's really scary. to be honest with you. It's scary because of the stuff I can't control. And that's really hard for me because I'm a fixer. I'm someone who finds a problem and fixes it and moves to the next problem. And there's a whole lot that I can't fix. There's just, layer upon layer of things to worry about. There's a big difference in the hospital as well. At both of the hospitals in McKinney, we're no longer doing elective surgery, and actually pretty much at every hospital nationwide, we're no longer doing elective surgery, which is most of the surgery that we do. And so we're not really operating right now. With the exception of C-sections, we're really not operating. From an OB perspective, it's the same numbers of patients because all those same people are still pregnant and still need to have their babies, but we're not letting them have more than one person with them.
For NICU, only one parent can be with the baby at one time. So if we have a mom that delivers a baby that goes to NICU, both parents can't be there at the same time, only one. It's been interesting. It's been very unreal.
The other component of hospital care that's changed is just all the precautions that we have to take. And so we have to protect ourselves and our staff at the hospital so that we're not exposed unexpectedly to the virus. And so we're having to wear a lot more protective equipment, or what's called PPE, to help protect us and keep us all safe, which means just adjusting our normal routines and getting used to what's normal now.
We have gone to masks and goggles in all deliveries.
Usually most of us are wearing like a medical mask and then putting one of those cloth masks over to keep our medical mask cleaner because we're having to use them longer than we used to, right? So we used to wear a mask, take it off, throw it in the trash, get a new mask even when we saw a new patient, and now we're wearing the same mask for several days. Also in the hospital, we're wearing caps over our heads. So I actually have one right here. This is like a little surgical cap that I made, and I put it on my head, and what it'll do is protects my hair so that I'm not having any contamination on my hair that comes home with me to my house. If a patient is known to be positive, COVID positive, or is highly suspicious for being COVID positive, we have to wear a special type of gown. And instead of just goggles, we have a face shield that comes down, kind of like a welder's mask that covers.
If we actually get a positive COVID patient, we have had training on it's called a PAPR, where, it's a full-blown helmet, looks like the stuff they wear in the movies. We are treating it much like flu when we have a positive flu mom that delivers. Babies' immune systems aren't developed yet. So we would get mom pumping so that the baby can get the antibodies, but we don't want the baby to get sick.
We don't really believe that there's what's called vertical transmission, which means that the baby would be born with it. But we do believe that babies that are getting it and getting sick with it are getting it from being present with mom afterwards. And so moms that are positive, who are known positive when they give birth, the recommendation is for the baby to be isolated from the mom for 14 days, which is brutal. I had a patient who was having some postpartum issues the other day, and I just wanted to go give her a hug so badly. And I had to just say to her, I really would love to be giving you a hug right now, but I know I'm not supposed to do that. And so just know that I wish I could give you a hug.
We haven't really been through anything like this before. Flu season is always a little worrisome because pregnant women get much sicker with the flu. So there's a little bit of some of the stuff we've had to do that happens every year, but we've had to make a lot more changes because nobody's immune to COVID. We're doing a couple different things. On the end of the workers, we're having as few people working in the office at the same time so that we can't infect each other. There's only one midwife in the office at a time. Similarly, we're only having one client come into the birth center at a time. We're not having anybody sitting in the waiting rooms. They're waiting in their cars, and we text them and tell them, it's time for their appointment. Obviously, we wear gloves all the time. And typically we don't wear anything. Midwives tend to not get completely gowned up, but we do have plastic surgical type gowns that we can wear. But the biggest change is just wearing the mask all the time. The hardest part for me is that midwives as a whole, and me in particular, tend to be like very much into therapeutic touch and huggy kind of people. And there's a lot that gets conveyed through the face, especially in labor and birth, where sometimes the mom, doesn't want to talk, or she needs more peace and quiet. But there's something about looking at someone's face where you can be very encouraging, like you can express a lot without saying anything. And because obviously there's not going to be a 6-foot rule in the birth room, we have to wear masks the whole time we're in there. And so that, and we're not as, we're not hugging people and we're not comforting in that way. And so that's a little unusual. And our clients, I think, miss it as well. That's the kind of care that they want. And it's hard to not kind of just jump in and do what we usually do.
I work on a general surgery floor right now, but since this whole coronavirus thing started, I work at Parkland, and Parkland opened up, they're calling it the TCU, it's called the Tactical Care Unit. So we go through a set of doors where we put on all of the protective gear, and then we can walk in. It's a very set process, and there's only certain people allowed back there, basically only nurses and doctors. Some executive leadership will come back there, like management and stuff like that, but pretty much it's just nurses and doctors. So we're really trying to limit the amount of people exposed and just keeping the amount of PPE, like the gear that we wear, to a minimum if we can. It can be a little scary, especially when the whole world has kind of come to a halt because of this, and you're just walking into, I don't really know what I'm walking into every day, but that's just how it goes. It's a really good experience though. I also know that I am being protected. So we wear, I guess I'll go bottom up. Let's see, we wear shoe covers, we wear surgical scrubs, so we change scrubs when we get to work. We wear a gown, and we have indicator gloves. So when we're in there, we never take these gloves off. We wear these gloves the whole time and then put another pair on when we go into a patient's room. We also wear the N95 respirator mask and a face shield and a hairnet. So it's a lot of gear, and that helps me be a little less nervous, I guess, is that I feel like I'm being protected. So of course, we're still learning about COVID-19. It is a relatively new, novel virus, but from what I've seen, it of course affects the lungs, but it also affects the GI system. So my patients tend to be very nauseous. They don't eat a lot. Sometimes they'll throw up, or they'll have a little bit of diarrhea. It also affects, they'll have fevers. They'll spike fevers a lot, and they'll tend to have a pretty continuous headache. Most days, it's just monitoring fevers. You're checking their temperature a lot. I am constantly watching how much oxygen my patients are requiring, because mostly that's the reason that they're in the hospital. They need some kind of breathing treatment, and they're requiring oxygen, which they weren't on at home. So I'm looking at how much oxygen they need. And I'm giving them medication, of course, for their headache or for nausea, trying to help them eat more, or seeing what I can do to help with their appetite and managing cough, that kind of thing. Technology is really playing a huge role in how we're treating the patients. We've got these big machines. Have you ever seen the big Apple monitors that are they're huge? They'll have one of those on a roll around cart. And I've seen the doctors use them for different kinds of things, like if they're putting in certain central lines, or if they're trying to consult with another team, they'll pull up the doctors on that, and then they'll put the camera at the end of the bed so they can see the patient lying in bed. But that's a really interesting part. They also have been able to use those machines for families. Like one of our patients, she was pretty elderly, and she was slowly passing away, but her family was able to talk to her and sing to her and kind of hang out with her virtually while this was going on. The scariest part of the virus, I think in my world, would be not only working with it and being in that environment every day, but wondering if I'm taking it home. You know, am I putting it on my mattress every night? Am I like giving it to my roommate that I live with, or my family, or other people that I go to see? Looking back at China and Italy and Iran and all of these other places that have had these crazy outbreaks, no one would have predicted this. And we're trying to get on top of it, which is why I'm really glad that we have these shelter in place and these orders that we have to close down certain businesses, because that's what's going to stop it.